Hey, everybody, we are live. That's right. You made it to our live class, and we're going to be talking about gastrostomy care. Do you remember learning this in nursing school? If this is a topic that you struggled with or you're not 100% sure what you need to know for NCLEX, you are in luck because we have a free NCLEX review and a question about it. And I'm glad that you're here for class. Hi there. Welcome to Winning Wednesday. My name is Regina Callion, MSNRN, and it is a pleasure to be here on International Women's Day. And so I am holding down Team ReMar today. And I'm just happy that you're here. We have to get into this topic, gastrostomy care. We'll be talking about the G tube. So come on in. You made it to the live class. Hey, if you want to get alerts whenever I go live, don't forget to subscribe to my YouTube channel. Let's get right into it. Okay, so when we talk about gastrostomy care, okay, and I'm going to be saying gastrostomy a lot, or maybe I'll just say G-tube. But anyways, we are talking about a feeding tube that is placed either surgically, endoscopically, or radiographically. But this tube has the intention to what? What is the purpose of this tube specifically? It is to feed the person. It is to feed our patients. They're feeding tubes that go through the skin into the stomach. So that's what a gastrostomy tube is in general. It is a tube that goes through the skin into the stomach. Now, you may hear this term PEG tube very often too. And PEG tube is a new way. Well, it's the newer way to place this kind of feeding tube where the patient gets the procedure. When we talk about an endoscope, it means we're putting the tube through the what? When we talk about the gastrostomy tube surgically, inserted through the skin, right into the abdomen. But the PEG tube is placed because it's an endoscope. It goes where? It goes down the mouth. It goes down the mouth, right? And so the surgeon is guided by the little camera that goes endoscopically, right? Okay. So that's the difference between a gastrostomy tube and a PEG tube. And I remember when I was in clinicals, I would always hear, oh, the patient has a PEG tube. And I understood what the function of the PEG tube was, but I didn't know how it got there. Like if somebody asked me how it got there, I would say, it just was placed through the stomach. But no. The PEG has a purpose. All right. So I'm so glad that we are reviewing this very, very necessary and clinical subject. Okay, so a patient has either a G tube or a PEG tube. We know what they have it for. So let's talk about, just the understanding of it again. I have here a picture where a patient has a G tube. All right, but they also have a colostomy with it, which is a bag that's going to be a collection bag. The jejunostomy tube is when that tube is inserted into the jejunum. And so there are a lot of terms that you want to be exposed to before taking your NCLEX exam, especially if you're taking next gen NCLEX, because it will be definitely more clinicals based. And so I'm just bringing up the jejunostomy tubes because sometimes when gastric feedings are not possible, then jejunostomy tubes are preferred for long-term feeding possibilities because they are going to deliver the formula past the duodenum into the jejunum. And so this is important because what it does is the pancreas is not stimulated in the same way. So, keep that in mind. Keep that in mind. I may have to do another video on jejunostomy tubes too, But we're going to specifically focus on the G tubes for this particular lecture. All right. But guess what? I do these every Wednesday. I also do Monday motivation too, where I study topics. So we together will be able to cover a lot of nursing information that you might have, missed or want to just review before your NCLEX exam. All right. All right. Now, let's go to talk about again what that procedure may look like for my visual learners. For my visual learners, we are literally going to, enter into that abdominal cavity. We are going to access, either parts of the stomach or the jejunum, like I said, and we're going to be inserting the tube into that space. So why would somebody have the surgical gastrostomy tube or a PEG tube? What are the indications? All right. And I just want to make sure that I am giving you guys all of my notes here. So just reading these bullet points with me, the surgical gastrostomy tube is for planned multiple gastric procedures. All right. And then we have here, when we are talking about the presence of esophageal obstruction, or if they have a colonic interposition between the stomach and the abdominal wall. So these are things that we are going to expect. These are things that are, they are a part of the understanding of the reason a person would have a gastrostomy tube. Now, I have previously said, well, what is the difference between a PEG tube? Well, the PEG tube is going to be reserved for short-term care, right? So maybe a person doesn't need a long-term treatment. And when I say long-term treatment, I'm talking about over 30 days. So the shortest, if I can just be very clear, when a person cannot swallow, cannot use their mouth, they have dysphagia, they have some other condition. Typically, if we think this is going to be, like a week-long thing, 2 weeks thing, what do we give them? How would we feed a patient who is having a very short-term issue with chewing, swallowing? What is our first intervention going to be? It's a tube, but what type of tube are we used to seeing? What did you say? NG tube. Very good. Hi there. Welcome to International Women's Day. Yes, an NG tube. An NG tube. And so NG tubes are usually reserved for less than 30 days. So less than 30 days, we're going to consider an NG tube because we don't want to give our patients surgery when they don't have to have surgery. Okay. So, and so when we talk about, well, the gastrostomy tube, this is usually for patients who are going to need long-term care when it comes to feeding. Now, I do see the comment here, TPN, total parenteral nutrition, and I will just say that is usually a last term resort. You would always want to have a PEG tube placed or a G tube before TPN. I go over this, you guys, in the V2. So if you have the V2, we talk specifically about the reason that the TPN is not ideal. And just very succinctly, the TPN, you're getting nutrition through your veins. Or here, you're getting nutrition through your gastrointestinal system, which is where food is supposed to go. So when you choose TPN and try to feed your patient through their veins, that is going to cause a lot of distress on organs, particularly the liver. Okay, so TPN is typically a last result. You don't want to put patients on TPN if you have the option to do a NG tube, a PEG tube, or a gastrostomy tube. Okay, great questions. I love the comments. It helps us to learn. So the PEG tube is just as important as the gastrostomy tube. However, it can be less expensive, okay? Because you are, accessing the stomach through the endoscopic route. And also, it is more time efficient. It is quicker. It is quicker. So the gastrostomy tubes are used to promote long-term nutritional support. So that just makes sense. The feeding of the patient, the hydration of the patient. What else? What other very important things can you put down a G tube that your patient may need to have? Okay. What are some other things that you can put down a G tube? I said you could put down food. You could put down fluids. Hi there, everybody. Yes, I know people are like, wow, you're here. I am a tad bit early today, and that is why I tell you guys, subscribe to the channel so you can get the alerts when I pop up live. Medication, exactly. When we talk about the reasons that we can give a patient a G tube, or we should, we are able to medicate our patients through this gastric tube, this gastrostomy tube. So absolutely, this is great. Meds. Yes. We're going to talk about that in a little bit. So we're able to give medications to clients who are having an inadequate oral performance. And so our nursing considerations are, hey, this is going to help a patient with long-term nutritional support. This is going to give you enteral access for medications. When we talk about patients who may need some assistance if there's a bowel obstruction, the gastrostomy tube will help them with that, and gastrointestinal or biliary interventions. And we are always considering, when it is good for the patient, but we also have to consider when maybe this gastric tube is not good for the patient. So if the patient has, these conditions, then the gastric tube may not be great for them. So gastric varices, when a patient has varices, it is going to increase their risk for what? It is going to increase their risk for bleeding. If a patient had prior abdominal surgery, so if a patient has had a prior abdominal surgery, then we have to make sure that the tube is not passing through the part of a bowel that is weak already, and that it is being placed in a safe condition for the patient. Yeah, good job. Varices bleeding. Okay. Obesity makes sense because patients who are obese typically have a thick abdominal wall, and that would make the gastric tube or the PEG tube difficult to place. And so the fat tissue can take up a lot of surface area for the patient. Well, pregnancy would be contraindicated, although there have been women who have had these placed during pregnancy, but typically it is later in pregnancy, the third trimester. But you have to consider, well, if a gastric tube is placed, that patient has to go under sedation, right? And so how safe is that for your pregnant client? You don't really want to assume anything. So it's a contraindication for now. Ascites can also be considered a contraindication, because what do we have? All right, we have the presence of additional fluid in ascites in the abdominal cavity. So if we put a tube we may have a fear that the patient may leak abdominal fluid, which puts them at risk for peritonitis. And so, although, gastrostomy tubes can be placed in patients with ascites, that patient needs to have a what? What is that procedure that will reduce the amount of fluid in the abdominal cavity? Can somebody tell me? You guys are doing so good today with responding to my clinical questions. I'm saying that if a patient has ascites, we know they have fluid in their abdomen, but they need a G tube. They need a gastrostomy tube. So what procedure can they have that will allow them to reduce some of that fluid? I see it. I see it. Good job. Not a thoracentesis, paracentesis. Very good. Very good. You guys are following me. This is how you pass NCLEX, by studying the content. Yeah, it's the paracentesis. Excellent job. All right. Let's look at the types of G tubes, types of gastrostomy tubes. Well, we kind of talked about it. Those that are endoscopically placed, radiographically placed tubes. Also, so when you talk about the tube, the function of the tube is always going to be the same. It is just really how it gets there, or when it gets there. Okay, so we have the endoscope, a radioscope, and then surgically placed tubes where we just go right into the abdomen, and then also replacement tubes. Replacement tubes are sometimes needed, and actually, when a tube is newly inserted into the patient, we are being so intentional that we do not have to touch that tube until it matures. Now, once it matures, after about 4 weeks, then if something goes wrong with that tube, it's able to receive a replacement tube. But you really do not want to be replacing G tubes early on, because it just causes so many issues with the surgical site collapsing, risk for infections. We want to give that tube time to mature and be functional. All right. So these are very, very, very important points to know about this topic. Glad you're here. The routine care for our gastrostomy tubes are going to be making sure that the external bolster is properly positioned. And let me just go back. The bolster, just to be clear, is the circular attachment to the tube. And so we call that the bolster. Typically, you keep that open to air. You keep that clean and dry, except for, after surgery, there may be some ointment that is placed so it doesn't get infected. But that is, I hope everybody can see that. That is called the bolster. And so we want to make sure that the routine care is ensuring that the bolster is properly positioned, maintaining a clean gastrostomy site. And normally that is, typically with just soap and water, keeping it dry, especially after you've had that site in for a longer time. It's a little bit different if it's new. And then flushing the tube to prevent clogging. And that is very important, as we know that we will be typically using that tube for a long time. And so we want to make sure that we're able to push our medications through it, feed the patient through it. And so flushing, usually it's 15 to 30 milliliters of water, should be performed after the administration of medication. So we learn this in clinicals a lot. Another thing that I wanted to say about that, I'm checking my notes. Oh, somebody had mentioned it. You do confirm the placement with an X-ray. Before a nurse accesses the gastrostomy tube, the doctor should write an order that says tube is ready to use, so that you know that you're in the right place. You can also aspirate the tube or check it for residuals, okay? And you can check for the gastric pH of the fluid that is coming out. All right. Somebody says, or pH, right or no? Yes, pH, but the x-ray is going to be more of a confirmation. The pH is not going to be preferred over the x-ray. Okay. We would expect the x-ray to be we would expect the residuals to be what color? It should be like a greenish color. Grassy green color. Let me read, what else are we saying? X-ray, okay. All right, good. I think we cool on that note. Let's go to the next point, which was okay, and then I also said leave the tube open, leave that dressing. Okay, no dressing, leave it open to air. Okay. Is it okay to flush it with Pepsi? So this is kind of controversial, but sometimes when a gastric tube is clogged, and even sometimes an NG tube, if it's clogged with like medication or old tube feeding and it hasn't been properly flushed, I was taught Coca-Cola, right? In nursing school, you hear people say you can flush it with Coca-Cola. However, that is not, I think that's a real world solution and not necessarily NCLEX solution. So we're going to reserve not to do that for your NCLEX exam. Okay. We're going to reserve not to do that for your NCLEX exam. Great question. Okay. Now let's talk about gastrostomy tube removal. And so because there are several types of gastrostomy tubes and the methods for removing the tubes are very significant. Typically, the nurses should not be removing the tube. Okay. It is done by experts. So if a nurse is removing a gastrostomy tube, she has been certified to work specifically with that tube. That means me as just like a general nurse, if I'm on the floor and there is an order for a gastrostomy tube to be removed, I would not be removing it. That also means that you would not be removing it. And so that's gastrostomy tube, PEG tube, replacement tubes, none of those things we remove. Now, NG tube, by all means, remove that NG tube. But NCLEX will trick you, and ask you if you can remove a gastrostomy tube. And I think most nursing students, if you haven't covered this topic specifically, you're like, why not? Why not? Let me give it a try. So, safety point, we don't have to remove these tubes. All right. Because, complications do arise. Complications definitely do arise. And so some of the tubing dysfunctions is that tube gets clogged, which we talked about. It is a very common, probably one of the most common dysfunctions of the tube is it's going to be clogged by either medication or tube feeding. And so when we talk about putting medications down a tube, those medications ideally should all be available in liquid form. Or if they didn't come in liquid form, then they should be dissolved appropriately in a liquid substance or in a water, right? And for medications that are not to be crushed, and you guys know the medications that we should never crush, right? If they end in certain letters, we should not be crushing them. So, if we have a medication that ends in what? EC, right? ER, give them to me in the comments. EC, enterocolic. ER, extended release. What do we have? ES, what's ES for you? SR, sustained release. Okay. What else? enterocolic, yeah, EX. All right, extended. Did I say that already? Okay, so those type of medications we don't ever crush to put down a tube. Everything else that we should be putting down should be either liquid or really, really dissolved very well. We also have the option of asking the healthcare provider, can we give a medication IV? Can we give a medication as an injection as well? Okay. Tube deterioration, the one thing that is going to denote a deterioration of a tube is what? What will we see that will be different on that tube that we will know that it is in fact deteriorating? Anybody have any guess? Okay. What we're going to see is displacement. No, it could still be in place, ideally, but what we're going to see, not infection. Infection is a different issue. You can have a perfectly fine tube with an infection. So we're going to see, what we're going to see is discoloration. So you can tell by discoloration of that tube. And so if a tube is deteriorating, we need to replace that tube. Hopefully it's mature enough for us to do that. Yeah, also leaking too. Absolutely leaking too. And that is going to denote that it's time to change that tube. Another aspect of gastrostomy tube failure is early deflation of the balloon. And so the balloon acts as the security of that tube in place. So the balloon inside is just like when we put in an indwelling catheter, we fill up a balloon so that it stays within the bladder. Well, if the balloon starts to deflate, then we're going to get the dislodgement or the dislodgement and then the loss of that gastrostomy tube. And so we definitely do not want that to happen. Tube feeding complications in general, aspiration. So when a client is receiving enteral feeding, we have to have a great deal of attention to whether or not that client is aspirating. And so the enteral nutrition has the propensity to do that. So we simply have to be very aggressive that aspiration is not taking place in our patient. And so that's making sure that we are, listening to lung sounds. We are, changing our patient's position, putting them in the proper position during this time. Diarrhea is essentially because when you have, all a liquid nutrition, then you are going to be more likely to have liquid stool, which is, diarrhea. Plus, our enteral nutritions typically have a high dextrose base, or some of them even use sorbitol, which is sorbitol is a non-absorbable sugar that can cause diarrhea. And so this is a complication. Metabolic changes, we talk about this even with TPN or other things. Yep, you're going to have hyperglycemia, you're going to have micronutrient deficiencies, and refeeding syndrome is something that you all should be very familiar with because it can be a potentially fatal condition when there is rapid changes in fluid and electrolytes. So if a patient has not been able to eat for a long time, for whatever reason, maybe, they were in a car accident, maybe they were, have dysphagia, and so they are not really tolerating food, and the family and the doctor make the decision, okay, let's just put a gastrostomy tube in the patient. Well, all of a sudden, the patient is getting, this high influx of fluids and electrolytes, and that could be potentially dangerous to the patient. All right. And you're going to have electrolyte changes. You're going to have the, hypophosphatemia, cardiovascular collapse, renal failure, rhabdomyolysis, seizures, delirium. All these things are going to be very possible during refeeding syndrome. So Constipation is a well-known consequence as well. Fecal impaction. Typically, patients with gastrostomy tubes are not moving around. They may not be getting the fiber. They may definitely not be getting the fiber that they need. So they have issues with constipation. Infection. I shouldn't even really have to explain how this is possible, but simply being in a hospitalized environment puts you at risk for more chance of catching an infection. Just simply being in the hospitals. Hospitals are the most, what can I say? They're dirty. Hospitals are dirty. And us as nurses going in and out of the hospitals every day, no matter what you believe, you are a carrier of many different diseases that, well, let me not say diseases. No, let me say diseases. You are a carrier of many different diseases, but because your body is so used to this environment, they don't affect you. But a patient who is coming from home or a nursing home, and they come in contact with you, and you put your hands on a surgical wound or an open wound, you can absolutely give your patient a hospital acquired infection, nosocomial infection. And I'll say this, when you are working in a hospital, you will find that you have separate clothes just for work, and you have separate clothes just for your home. And so that just goes to, like, in your mind, think about it when you're coming in contact with, your sweet little elderly patient. Understand that you are probably one of the biggest risks to that elderly patient, because nurses in general, do you guys know what we typically carry on our skin? We typically have it in our nose, we have it in our mouth, we have it under our nails. It's actually staph. Yeah. Staph typically lives in your nose, in your mouth. And so if it gets to a patient who is not immune strong, staph in the skin, in a wound, can wreak havoc. Yes. And so patients, when they get staph infections, when they get like a MRSA or a staph infection, it's difficult to treat. All right. Let me see, where did I leave off? I got off on my rocking horse of infection. Okay. Bleeding. Yes, is that next? Bleeding can happen after a gastrostomy tube placement. It is rare. It is rare, but it can happen. And so we need to make sure that before we even do the surgery, the patient has normal coagulation parameters, and that will help from, prevent the bleeding. Peristomal leaking occurs within the first few days, typically after a G tube has been placed. And essentially, we are looking for reasons why, right? So does the patient have issues with their malnutrition? Do they not have enough protein, or what is it, that's causing the leaking? Maybe their poor wound healing ability because their diabetes, mellitus is kind of poorly managed. So those are kind of reasons why. Also, if the tube is too big or if it's too small, you might have that problem as well. Ulceration of clients may be related to the internal bolster or the external bolster, where it is in contact with the skin constantly. Your skin is not used to having something like a bolster or a balloon touch it all the time. So the skin will begin to break down, and ulcer can form because now you have this tube sitting on your patient's stomach, or this bolster sitting against the skin, not comfortable. And also the skin is like, hey, get this thing off of me, get this thing off of me. Gastric outlet obstruction, you know what that means? Essentially, where the tube can either shift out of place into duodenum and cause a gastric outlet obstruction, where it's obstructing something that is not supposed to be. So we want to just make sure that it is positioned properly. And then here is the last complication, is essentially what it sounds like: leakage of gastric contents into the peritoneal cavity, which is not Great. That's my clinical term for that. It's not great when that happens because it puts the patient at risk for peritonitis. Peritonitis. And so that can be a combination of the the natural gastric contents. It could also be if a tube feed or a medication is leaking into the peritoneal cavity while, it could be a spectrum of things that we would need to treat. And so if peritonitis develops, then we have to stop the tube feed and we have to start antibiotics on the patient, and they have to go through, surgical consults. And it is a very, very, very complex condition to treat. And we don't want our patients to have to go through this. Okay. So when, we talk about the idea of just putting a tube in our patient's stomach to feed them, but we need to be mindful that the patient and the patient's family is going to be hearing all these possible complications, all these things that could arise. And guess what? Guess who they're going to ask the questions to? They're going to ask the questions to their nurse. Well, how? How could this have developed? What does the doctor mean we have to put in a new tube? Why is the skin breaking down here? Why aren't you covering this gastric tube? Look at it. It's just laying out. Does it need to be covered with a Band-Aid or a dressing? These are the types of concerns that non-clinical people have when they see this thing. Okay. When they see this gastrostomy tube, it makes them afraid. All right. And so that's why we have to be the voice of comfort, but also we have to be the voice of knowledge, because we can't say, let me go get the doctor to explain that to you. All right. It doesn't make the family reassured that their loved one is getting the best care when the nurse doesn't really know what's going on. Okay. So content is how you keep patients alive. Content is how you keep patients safe. It's how you keep patients safe. Okay. I think that's it. Let's try to do a practice question. Okay, guys, here is our first one. It is this. The nurse was assigned in a medical surgical unit. From the following clients, who is highly recommended for a gastrostomy tube insertion? Okay, is it number one, a client with dysphagia secondary to stroke? Two, a client with a history of tonsillar cancer? Three, a client on 3 days post-operative partial laryngectomy? Or four, a client with recent diagnosis of Hirschsprung's disease? What do you guys say? We're talking about who is most appropriate for this. As I reach for quick facts, who is most appropriate for this gastrostomy tube? Were you paying attention? Did you arrive to class on time, or are you just getting here like, what's going on? Okay, I see some ones and threes. All right, and I'm happy to say that the majority of you did pick the right answer, which is indeed one. Great job, everybody. The client with dysphagia secondary to stroke. Clients who have been having dysphagia for more than 3 weeks is commonly found with clients who've had a stroke and would highly benefit from the gastrostomy tube to prevent aspiration. All right, without sacrificing nutrition. That's right. That is right. And a lot of people, I just want to go back. A lot of people pick 3, a client on 3 days post-operative partial laryngectomy. Okay. And This is not the right answer because remember, when we talk about gastrostomy tubes, we are talking about a long-term therapy. And so the partial laryngectomy, we would expect that patient to heal and be able to eat again within 30 days. Okay. All right. Somebody's asking about the client with the recent diagnosis of Hirschsprung's disease. Hirschsprung's disease. Somebody put that in the comments for me. What is Hirschsprung's disease? Okay. And put that in the comments for me. Okay. And so we're talking about the patient, we are talking about the patient who is highly recommended. All right. We are talking about the patient who is highly recommended. And so, although you may have patients who are appropriate, even though I don't know if this patient would be appropriate. Okay. I'm not sure if the Hirschsprung's patient would be appropriate depending on the severity of the disease process, because if I'm not able to absorb the nutrients in my large intestines from food, does it make sense for me to put food there? Think about it. Okay. So it says a condition of the large intestines which has difficulty passing stool, has been unable to pass stool. Okay. So essentially, if you're putting large amounts of fluid into a container that is going to hold on to the fluids, right, or not absorb the food, does it make sense to use that route? Would TPN be more appropriate? Okay. So we're talking about, and that's the thing that makes NCLEX questions, challenging sometimes, because you may be able to come up with a rationale. You may be able to come up with a rationale why more than one can be right, but you have to pick the best choice. Okay. All right. Let me move on. We can come back to this, guys, if you want to. Question number 2 says this: a client with ascites is recommended gastrostomy tube after a paracentesis. Okay, after a paracentesis. The client is adamant to undergo paracentesis. The nurse explains that this procedure is needed for the following reason. Is it dehydration, peritonitis, bowel obstruction, okay, or bleeding? This is good. I'm not even going to elaborate on this one because the challenge of this one is actually reading it. Okay. Let me reveal the correct answer, and I will allow you guys to make comments on it or ask me questions about it. The correct answer is going to be peritonitis. Ascites is contraindicated, and I mentioned this during the lecture. Ascites is contraindicated in the gastrostomy because the abdomen is filled with fluid. So a paracentesis is going to remove that fluid, and it is needed because when a patient has ascites, then there is a risk for peritonitis. And so that paracentesis has to be done because the client is with what? The client is with ascites. Does everybody get that? Is there any questions about that one? Let me know. Because see, what happens here is that you were given, people are saying, when are you going to do next gen questions? This is a perfect next gen question. That was not an ordinary question. because you literally had to do 3 of the clinical judgment measurement model steps, probably 3 or 4. You had to recognize the cues, you had to analyze the cues, and then you had to make a hypothesis about why the paracentesis was needed for ascites and then the gastrostomy. Can you explain more of it? Hey, did you are you just jumping in, or did you catch it from the beginning? Because some of you guys need to watch the replay, all right, of the video, because we did go over the complications and the indications for the gastrostomy tube. Okay, so just in general here, one of the challenges is just reading what is the point of this question. The point is very much about the actual paracentesis and not about the gastrostomy tube here. Says the client has what? Ascites. And the recommended gastrostomy tube will come after the paracentesis. But guess what? The patient is probably thinking, why can't I just get the gastrostomy tube? Okay. Why can't I just get the gastrostomy tube? The client is adamant to undergo paracentesis. So that's what we need to be addressing. The client is adamant to undergo the paracentesis. So the nurse explains that this procedure is needed for the following reason. Okay. Why would the patient need a paracentesis? Are you guys following me now? All right. The patient needs the paracentesis because, not because of dehydration, not because of a bowel obstruction, and not because of bleeding. You don't see those things. The patient needs the paracentesis so they don't have peritonitis. And so you have to make the connection between the ascites and the gastrostomy tube, because you can't just go from ascites to gastrostomy tube. You have to have that step in between it. So you have to know the function of a paracentesis in this clinical scenario. Okay. All right. So we are talking next gen here because the focus is more on a clinical understanding in real life. Current NCLEX questions would have said, what is ascites? What is a paracentesis? You know, why does a patient need a paracentesis? Next gen questions are going to say, your patient is a 62-year-old client with ascites that needs a gastrostomy tube and has an order for enteric feeding. What is the priority of the nurse? You know what I mean? Can the nurse carry out this order? It's so different. It's so clinical. And so if this question confused you, I'm glad you're here today, because we are going to be learning. We're going to be learning about the connection to nursing priorities. It's not easy to be a nurse, but it is worth it. Okay. All right, so peritonitis, I got to move on. The newly assigned nurse is caring for a client with a gastrostomy tube. The nurse should know that a replacement tube is inserted once the gastrostomy tract fully matures around, is it 1 week, 2 weeks, 3 weeks, or 4 weeks? And I should see these answers coming up very quickly because we did already discuss this on 2 different learning points tonight. And so I'm liking what the ReMar nurses are commenting on. All right. Perfect. The majority of everyone is saying it is number 4, and I agree with you guys. So it is typically well matured 4 to 6 weeks. So they begin to mature after 1 to 2 weeks placement, but it is well matured 4 to 6 weeks. So it is important for us to wait at least 4 weeks to prevent dislodgement complications. All right. Can we use this lecture for next gen questions? Please, 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 please. Definitely use this. Use all of my lectures for next gen, because remember, when we talk about next gen, We are still talking about human anatomy. We are still talking about clinical procedures. We're still talking about medications. And so the same information that we're discussing now is going to be applicable to next gen. It's going to be more on the presentation. Okay. Marie, if you don't get it, watch it from the beginning. Okay. Watch this lecture from the beginning, because gastrostomy is a very clinical topic. And so usually it is tough, maybe if you're a hands-on learner, to make the connections to how it all works. Okay. Okay. Good job. Question number 4 is this. The nurse cares for a client with a new surgical gastrostomy tube. Identify the best nursing action for the client's routine of gastrostomy care. Number 1, initiate enteral feedings right away to prevent malnutrition. 2, add tension to the stoma to ensure balloon is in place. 3, cover the wound with thick dressing to keep it dry always. 4, apply antibiotic ointment to the insertion site to avoid infection. What are we going to do? I see some 2s. I see some 3s. I see some 4s. All right. This is a great question because it is creating multiple different responses. And so that means there's an opportunity for all of us to learn about how we are to answer this NCLEX question, because there is a clue in this NCLEX question that we all should have been alerted to. And that clue is that this is a what kind of gastrostomy tube? It is a new surgical gastrostomy tube. So we need to make sure that the wound is not at risk for infection. Okay, so the correct answer was number 4, apply antibiotic ointment to the insertion site to avoid infection. So number 1, initiating the enteral feedings right away. Not right away. We got to get an order. No. And preventing malnutrition, that is not the priority at this point. You got a new surgical appliance. Adding tension to the stoma. Why would we add tension? That means we're pulling on it. That means we are manipulating a new surgical tube. Do we want to do that to ensure that it is in place? A lot of people pick number 2. Number 2 is dangerous. We don't want to do that. 3, I told you guys, this gastrostomy tube, remember, this gastrostomy tube, we like it open to air. We don't want to have a thick wound over it. We need that skin to be dry. We need that skin to be open to air. Okay. And so this is safety. This is safety right here. You have the clue that this was a new surgical gastrostomy tube. And so that's it right there. Okay. All right. And so you must, says, I don't always think of bleeding and infection post-op. That is the major time you should be thinking of it, because the person otherwise would not have a wound. When you think of surgery, you got to think of a wound, because there is a new wound. There's a new cut that is not supposed to be there. So who's responsible for keeping that thing clean? It's going to be you. It's going to be you. So you need to always be thinking of fever, right? Infection, redness, pain. Okay. And so is the grammar that confused? What about the grammar? What about the grammar confused you here? All right. So this is, this is This is how we have to approach these questions. This is how we have to approach these questions. All right. Last question for tonight. The nurse assesses a client's gastrostomy tube for deterioration. The nurse should look out for, number 1, loose fitting of the tube. 2, redness of insertion site. 3, discoloration of the tube. 4, client reports pain during feeding. What do you guys say? Okay. All right. I know if you were on time for class and you showed up for class, you're going to get this right. Okay. Great job, everybody. The correct answer is absolutely 3, discoloration of the tube. If the tube is not regularly sterilized, it can lead to faster deterioration. We also talked about it being able to leak or break as well if it's deteriorating, but usually it could be recognized by the presence of discoloration, irregular beating of the tube, and an unpleasant odor. Okay, so that word needs to be remembered, deterioration. Okay, guys, I am going to say Winning Wednesday was a success because we had over 400 students joining on tonight, and you guys rocked the gastrostomy tube lecture. So I hope feel more comfortable about the difference between just a basic gastrostomy tube and a PEG tube and a replacement tube, right? And you also feel like your Wednesday was worth it, because even if you didn't study on your own, you came here and studied with me. Okay, so questions. I'll take some NCLEX questions here. Here we go. Nice job, 4 out of 5. I have a question. I'm new to your page and your content. Where would you suggest I start in terms of preparation for NCLEX? I say, like, if you're just really new and you're just trying to figure out, like, who is this person? What does she do? How did she get here? Quick facts for NCLEX. Start here. This is my go-to question and answer book for the NCLEX exam. You can get this book on Amazon or go to my website, remarnurse.com. If you like the lecture style that I do, like we did tonight, I would suggest you start with a free trial of my NCLEX review. I have a full package, but you can sample a portion of my lectures right now to see if they are helpful to you. And when you sign up at remarnurse.com, you just start watching videos and you'll be able to see if this is the method. I say for nursing students who are preparing for NCLEX, try to do these 3 steps in your preparation process. And that is watch something. So watch a lecture, write something down, take notes, and then you can answer questions later. But those 3 things, if you're doing those 3 things, they will help you retain information tremendously. Okay. All right. Thank you so much. I wish NCLEX was this easy. Let me tell you something. The questions that I presented you guys tonight were very challenging. The only reason why you may be feeling like they're easy is because I actually told you the answers beforehand. I literally reviewed the topic with you guys before I gave you the test. And so that makes it so much easier. Okay. All right. Other questions. What time does class start? Yeah. So class typically starts at 9 p.m. I started the class early, about 8:30 today, because my schedule needed me to do that. So that's why I always say subscribe to the YouTube channel, because sometimes, I have other commitments. And so because I do this free, because I do this as just a gift to my community, well, just, keeping it real, all of my kids are sick right now. So this is International Women's Day. And when I get off of here, I take off my ReMar hat and I put on my mom hat. And so my mom hat is like all the kids are sleeping right now. You need to do Winning Wednesday immediately because Mark is not home. So it's literally me, you, and 3 sleeping kids. And I don't know what is going around right now, guys, but like my daughter, she's still struggling, sick. I've been in the doctor's office, at the hospital today. And I'm like, man, it's International Women's Day. And women, we're out here doing it for the community. So I'm happy to be with you guys tonight. And I was happy I was able to get through class. All right. Somebody says, Lydia, send me an email. Okay. Will I teach tomorrow? Tomorrow's Thursday, so I don't do a live free class. But if you have my virtual, my V2, my NCLEX review program, you could just go in there and pick up from your study session where you're supposed to do. NCLEX is changing next gen. Yes, it is changing April 1st. If you guys follow me on TikTok, I'm doing a countdown on TikTok. I'm actually also going live on TikTok a lot, talking about next gen. You guys are welcome. What else? What's going on with my daughter? I'm not really sure. You know, you guys, last Monday, I told you she got strep. She just, she started antibiotics. She wasn't getting better. I had to work. So she stayed with my mom for like 2 days for me. And then when I saw her after the 2 days, she was like thinner, sunken in. She hadn't been eating. So I took her back to her pediatrician. Pediatrician said, it's not strep anymore. But she still had like swollen tonsils and the whiteness. Remember, you guys were like, if there's whiteness on the tonsils, it's strep. But it's not strep now. So we check for mono, we check for COVID, we check for flu, none of that stuff. So we're still trying to figure it out. When will you be uploading the 30-day challenge videos? All of the 30-day challenge videos are up there. Now, what you guys may see is that there's 20 videos. And you're probably like, why isn't there 30 videos for the 30-day challenge? The reason is because in my study calendar, you see rest days. I only have you studying 5 days a week. So it's a 4-week program. So that's 20 study sessions. So there's 20 videos that are ready for you. Okay. Thanks for the live class because you didn't have to do it. I didn't have to do it. But I said to myself, I'm always telling you guys that, you have to, push through challenges. It's not always going to be perfect, but you just got to do it. And so I was prepared. Literally, I got on tonight, but I was prepared to shut it down at any minute. If my daughter called for me, or, one of my 2-year-olds started crying, I was going to have to say, peace out, y'all. I got to go. And I just trust that we have a relationship that you would know that I was doing what's best. Thank you so much for the prayers. Okay. Can this study strategy help with class exams? Yes, it should be. All of the content that I review is appropriate for nursing school. So even though I talk a lot about NCLEX, what I find is that if you understand the major points for NCLEX, nursing school gets easier. And so sometimes even nursing students will take my NCLEX review during nursing school. So it will prepare them. But anyways, at the end of the day, you should at least have quick facts, if nothing else. Okay. And I really like the topic gastrostomy tubes today. I don't typically talk about G tubes or PEG tubes, but I do want to shift to more of a clinical component for next gen. This is a great question. What do they mean by blueprint? I'm assuming that somebody or in the NCLEX community, they have mentioned a blueprint for the exam. I think that is a fancy term for test plan, or it may be the same term, but essentially the National Council State Board of Nursing, they release a test plan of all of the possible topics that could be on the exam. And so if a person is in an NCLEX reviewer capacity like myself, they should be referencing that test plan when they create their products. The dangerous thing and the reason why you guys have to watch out for scammers is because the it is very easy for nursing students to be preyed upon. Okay. It is very easy for you guys to be taken advantage of. Number one, because you are sincerely looking for help. So if a person is saying to you guys, I will help you get your nursing license and I will give you the questions on the exam, nursing students are like, oh yeah, you know, you guys get interested in that. Another thing is that nursing students understand that there is a price, there is money that has to be paid. And so I'm saying all this to say that if somebody is offering you an NCLEX review, make sure that they are referencing the test plan, the current test plan, and they have a way for you to get through their materials. Beware of the person offering to help you for NCLEX that is going to sell you test questions from the actual exam. Don't fool with those people. Don't fool with the people that are going to give you, 10,000 flashcards, because you really have no idea if this material is actually going to be on the exam or if they just computer generated it. Okay. Yeah, so that's what I'm gonna say. That's what I'm gonna say about that. Anything else? Anything else? That's a good question. How should one study after failing at 145 questions for NCLEX RN content or questions? Okay, so you must be new here. I specialize in helping repeat test takers pass the NCLEX, meaning that probably the majority of the nursing students who watch me have already failed NCLEX, and then they find me and they start over. So I would suggest that you start with content, doing just what we did today, taking a subject, sitting down with it, going over the major points, meaning what is the term, what are the symptoms clinically, what are the possible treatments. There's always two ways to treat a condition. There's a medical and there's a surgical. You need to be able to be comfortable explaining, discussing both of those treatment methods. And what else? Nursing responsibilities as well. And then you can do questions later, much later, but you see the work that needs to be done first. I used you for my LVN NCLEX review. I came back for the RN. Congratulations. I'm glad to see you back. I love my ReMar nurses. Okay. I have a friend who is a retired RN and she finds your quick facts to be very useful. She asked if she could use my book and I told her you could purchase your own. Yep, you purchase your own. That's true. That's true. The quick facts book, literally, I'm just shocked at how that book gets around. Okay. What about the question bank? Do you want to know? Where can we find the Q bank? ReMarNurse.com. ReMarNurse.com is where my question bank is. Okay. And my question bank, I was on TikTok and I was talking about my question bank and somebody asked me, could they just purchase the question bank and not the lectures? No. They said they just wanted the lectures and not the question bank. And so I told them that the lectures are the priority and I don't sell them apart. I sell them together because I think that they're both useful, and literally the price of my program is like, why not have both? My program is literally like $20 a month. It's $89 for 3 months access. So you get all of my lectures, full lectures. Actually, my program is this. Some people think my program is just this. They say I'm doing ReMar and I just have this book. This is not my program. This is a portion of my program. This plus this is my program. So your downloadable workbook that you get to take notes in. Remember, I said taking notes is important. Plus quick facts, plus the question bank. That is my program. So I like quick facts. I think it's just as important. But the notes that you take, like me taking all these notes, the notes that you take here are going to be just as important or even more important than what's in this book, because the stuff that you take here is stuff you didn't know, right? You're writing things down. Can V2 help with the HESI exit exam? V2 can help with exit exams, only because I say that because the HESI exit exam is a lot like NCLEX. And so the HESI tries to make sure that they ask you similar questions. I remember taking my HESI exit exam in nursing school, and I found it to be very similar to NCLEX. So if you do an NCLEX review, you will pick up those major, actually remember questions. I was more afraid of the HESI exit exam than I was the NCLEX. So I actually remember the questions on the HESI exit exam because they traumatized me. I thought it was very challenging. Yes, I think there is. If you go to the website, you'll see what is included in the current V2, but you definitely get the, I think it's on sale, still on sale for $89. You will get the quick facts book, the question bank, the lectures. If you already have this book and you want the program, it's just $69. So the price goes down. If you don't need this book because you already have it, it's $69. If you are taking next gen, pretty much everybody that's watching this is more than likely taking next gen. I brought the V2, but I didn't get the, email me. I can send you the workbook. The workbook should also be in your file vault as well. The downloadable workbook is in the file vault of the V2. I don't ship that out. Okay, but I was trying to answer one question. Where did it go? Oh, I'm now preparing. Let me post a question so I can, no, not this one. Hold on. It was this one. I'm now preparing for the NCLEX examination. I have to do the next gen. I started on content. Yes, that's where you start. You start on the content, you focus on the questions later. Good job. Is it a bad idea to just study content and not do as many questions? Or how many questions should we be doing while studying content? I test at the end of March. That's a great question. I'll say this. With my program, I have you studying about 3 hours a day, 2 to 3 hours a day, no more than that. So I would say if you are testing at the end of March, your content should already be covered. You should have already sat down and looked at the topics for that, right? And so right now you should just be primarily focused on doing questions. You should be doing your practice exams pretty readily. So let me know, Latoya, because I want to know, do you feel comfortable with the content? Is it a bad idea to just study content and not do as many questions? How many questions should we be doing? Because if you are testing at the end of March, your question should be the priority. But if you still find that you need to study content, then you might need to move your test date. That's all I'm saying. That's all I'm saying. It, to me, is much better to be prepared for the NCLEX than just take it and get it over with, because it's so expensive to apply for it and it's so expensive to, register for it. So if you can, it costs you nothing to change your date if you need to. For me though, it takes me about an hour to do 10 NCLEX questions. And I know that may seem like that's a lot of time, but look how long it took us to do 4 NCLEX questions. It took me a while because I actually sat and, we talked about it. And you guys should be doing that yourself. After you do an NCLEX question, you should be sitting down and looking at the rationale. Like it should be something that you can say, oh yeah, I see that. Or no, I don't really understand this. Let me take a minute. Don't try to do, 100 NCLEX questions a day. And then at the end of it, you don't really know if you had learned anything or you have retained anything. You're just rapidly doing questions. Okay. I did my NCLEX 3 years ago and I failed. I'm studying to take it again, but where should I start? Start from the beginning. Just start from the beginning because you're going to get a brand new test. Every time you fail NCLEX and have to take it again, you get a brand new test. So you have to start all over again. because you don't know what you're going to get. A lot of mistakes that nursing students make are they look at their CPR, their candidate, report, and they say, oh, I was below in psychological concepts, or, oh, I was below in basic care and comfort. So let me focus on that for my next NCLEX. And then they focus on those subjects, don't really look at management of care, don't really look at, parenteral therapy, pharmacy. They don't look at those things. And then when they take their exam, hoping that they're going to get the basic care and comfort that they have been studying for, they don't get, the test is majority like maternity, all right, or pediatrics, something they didn't focus on totally. And they're like, what? The test will give you a totally new exam. So start from the beginning. In my program, I start from pediatrics and then move you throughout the lifespan, so we don't really miss any big sections. All right. I'm expecting to graduate May 2024. Congratulations. When should I purchase the V2 content? Well, you didn't tell me what type of program you're in. So maybe you're in a bachelor's program. Is it 3 years? I would say your senior year, you can do V2 your senior year. Before your senior year. Like if you have a break in the summer, you could do it before your senior year. So going into your senior year where, you are doing lots of clinicals, lots of high level nursing tasks, you have the support. I didn't know that nursing students were doing this in my class. They had taken an NCLEX review over the summer. And I would be sitting there in class like, how do you know that answer? Like, you know what I mean? And then they said later on, like, oh, we did an NCLEX review over the summer and it explained. I'm like, what? That was a hack I wish I knew. But see, I didn't have a lot of friends in nursing school. That's a different story. But yes, the NCLEX review will help you do a lot better. All right. So get in my V2. And the whole time I had quick facts in my, oh man, that's a whole other story. Okay, guys, I really enjoy hanging out with you, answering questions. What else? Because I'm going to get out here. Actually, I need to get back in the V2. The reason why the computer adaptive test in the V2 is almost ready to go. The developers said that I needed to add 4 more case studies for the computer adaptive exam. And so it is, I need to add 4 more easy case studies for you guys. So that is the reason why the computer adaptive exam is not populating, because I need to put those case studies in there. So it's on me. It's not V2. It's literally me. Somebody says this. Hi, another question. I've been hearing that content is content as far as the NGN. Should I stick to my test date this month or push it back? What is content is content? What does that mean to you? I would only say that if you don't feel comfortable, when you are ready to take NCLEX, you feel like the term is saturated. I like to use that term. It basically means you don't feel like you can learn anything else. Or if I'm doing a lecture, you're like, I know this stuff already. I already know this, Regina. I already know this. I know what, and so you have this feeling like, I just want to get it over with. That's how it should be. Like, I can't study this stuff anymore. I just want to go take this test. That's the attitude you should be having. I'm ready. But if you have attitude like, I don't really think I haven't really been consistent, or I didn't really finish the resource. Like some people have quick facts, but they don't memorize it, or they don't know all of it like they need to. I would say, then you should evaluate whether you're actually ready to take it. That's what I'll say. Yeah, I answered this. How do I make the CAT on the test work? The V2 is waiting on me. I need to put 4 more case studies in that. I am planning to do that this week. However, I've been having family issues. My daughter has been, really sick. So it's prevented me from accomplishing some task that I wanted. But it populated that it was active, but then, it's waiting for me to put those easy case studies in there. So please, my apologies for that confusion right now. I finished the content now. This is the question for the question bank. I will not take next generation. Okay, yeah. So in my question bank, although there is next generation items, you don't have to take them. And so, for example, if you want to create practice quizzes, you can uncheck the next gen case studies and next gen item box. You don't have to take it. Okay, you don't have to take those. The computer adaptive though will have the next gen items on it. I apologize for that, but I have to get ready. The test is literally changing in a couple days, so I had to put the next gen items in there. Regina, I feel the next gen is easy. Is the V2 we purchased viable for V2, or we need a new one? I'm not really sure how to make this out, but the next gen is it's easy for people who are comfortable with the clinical concepts of nursing. It's easy for people who like to read charts. It's difficult if you have not been exposed to it. It's difficult if your nursing school has not addressed next gen at all, and you don't really know about it, and the teachers are like, it's a mystery to us too. And then you have to take the exam. So I think to say it's easy, it may be easy for you, but it could be challenging for other people. But hey, you have to be comfortable. So if you feel like it's easy, go for it. Get that nursing license. We're all cheering you on. All right. Yes, I am. I'm going to get that together for you guys. What else? Anything else? This is a good question and answer session. Great questions. Okay. I'm so late. Yeah, we're finished up. We did the topic. And so now I'm going to get off here, guys. I will work my hardest to get that computer adaptive testing up for you, hopefully by the weekend. What's today? Today is Wednesday. So if today is Wednesday, then that means tomorrow's Thursday. And it's going to be another opportunity for us to be great. Right. So let's do that. Let's just keep pushing forward to the goal. I will be back for sure on Monday to cover the topic of the week for Monday. And then we're going to do another Winning Wednesday. All right. So many questions. What is it? I need to go over hemodialysis, please. I did check out my YouTube channel for hemodialysis. I did peritoneal dialysis and hemodialysis already. It's already on there. Is the $89 package same price every month? So right now, this is our introductory price. We launched the V2 early back in Black Friday, and we dropped it with the $89 price. And then, students really appreciated that we weren't charging like $100, $200. So we've been keeping it at that price, but we do expect it to change at some point. We just been trying to show love to y'all who really are strapped for cash. Has the content changed with NGN, or is it the same content as before? Generally, the content is the same. The presentation is different. There will be a more emphasis on pharmacology, and there will be more emphasis on management of care questions. Okay. What is your question, Elta? Okay. My test is next week. I'm so stressed. Can't be stressed about it. You picked the test date. It's not a surprise to you. You knew it was coming. You actually should be saying, I'm looking forward to it. I'm looking forward to it. All right. So instead of putting, you didn't answer my question, just put the question again, because that'll help me. All right. So just put the question, because literally I have comments. A lady asked advice for someone that left school since 1990. Okay. So you didn't answer her question. Yeah. So you haven't been in school since 1990. That's okay. That's a long time to be out of nursing school. Would I repeat nursing school? No. Would I just do an NCLEX review? Yes. Because the nursing information, as far as anatomy and physiology go, as far as diabetes mellitus goes, as far as congestive heart failure, there has been not any new mind-blowing revolutionary discoveries. In 1990, people still had one heart, two lungs. The organs have not changed. Congestive heart failure has literally not changed. Psychiatric conditions have been the same for hundreds of years. So go ahead. Go ahead. Actually, you know what? Do yourself a favor. Go to remarnurse.com. Get in my trial program. Go to my website, get in my trial program, and just take one lecture. If you understand it even a little bit, if you are like, hey, I'm following you, I know what you're talking about, you're on the right track. Everybody should be in my trial program on here. If you're either in V2 or you're in the trial, that's it. Any advice on what I should be doing the 6 days to my test? If your test is in 6 days, got it. I see your question now, Elta. If your test is in 6 days, you should be doing for the next 5 days practice tests, quick facts, and then the day before your test, nothing. Whatever you don't know before your exam, you just won't know. That's it. Don't study. Give your mind a full day's rest, because that next test day, you're going to have to be prepared to go for 5 hours. Okay. What is your advice to me as a foreign nurse about NGN? It would be the same as I have been given foreign nurses in general. You have the burden of making sure that you're prepared. And so that means absolutely taking an NCLEX review. If you were foreign educated or you have your license in another country, 9 times out of 10, the standards here in America are higher for nurses. We carry a ton of responsibility as nurses here. So you will more than likely have to learn a lot of medications, a lot of clinical procedures, a lot of surgical procedures. You will be expected to anticipate care. Okay. You will be expected to identify contraindications or reasons why patients should not get certain things. And you will not be able to get your license until you are competent in all those areas. So what that means for you is you need essentially a very structured approach to this exam. And it doesn't matter that it's next gen, that doesn't matter. What matters more is how you're investing your time in learning the content. Because next gen, most people, when they talk about next gen, they're talking about the questions. Okay. But next gen is so much more than the questions. It is the approach to the material that changes. And so, again, the more familiar you are with your nursing science, and we call it the art and the science of nursing. Okay, so the art is how we do it. The science is why we do it. The more familiar you are with our standards here in America on that, the better off you will be for next gen. Okay. Yeah. Okay. I purchased V2 end of January. I'm due for a renewal end of March. Do I not get 3 months access? Because that will only be 2 months only. So when you renew for V2 after the 3 months, you're renewing 1 month at a time. Okay. 1 month at a time. If you go to your profile in your V2, it will tell you exactly the date that you are going to be charged. Now, when you purchase the V2, you have the option of postponing your start date. So if you want to purchase it for $89 but don't want to start it until, up to 90 days away, you can do that. So I don't know if you postponed it. Maybe it may be, you didn't start it the first month right away. You postponed it. But your profile will tell you when you will be charged for the renewal. Or also you can email support@remarreview.com to ask Team ReMar. Okay. Okay. What did somebody say? I'm currently enrolled. All right. If you have any specific questions about your specific account, please email me, because I can't do specific, troubleshooting of your personal account right now. I'm live. I don't have access to anything. Does the trial have the 30-day challenge? Yes. Trial has the 30-day challenge. What pharmacology book should we use? We should use this book right here, Quick Facts. In the back of Quick Facts is the pharmacology section. Start here. Honestly, if you memorize the pharmacology section here, you will be in great shape for NCLEX, because a lot of these are the major medications, and so if you do that, you will be in good shape. So yes, if you get in the trial tonight, guys, get in the trial. You will be able to watch lectures and do some of the practice exams. The only thing is, in the trial, you won't have access to my question bank. That only comes when you upgrade from the trial. So otherwise, you can still get a feel for how you should be studying. Remember, I said, watch it, write it, do questions. And so I'm glad, Patricia, you like the V2. And that is what, that is how you pass NCLEX. You have to be excited and enjoy the studying process, or you won't do it, Okay. So make sure that you are taking proactive steps to do what you need to do. All right, guys. I'm going to do something that I don't normally do now that we have. I'm going to do a lecture from the V2 for those of you who will go get into the trial, so you can see what the lecture portion is like. Okay. And I will allow you to experience the V2. I have a video that I wanted to play, so I'm going to do that right now. All right. And then I will see if you have any questions about V2. So I will be back, guys. Diabetes insipidus versus syndrome of inappropriate antidiuretic hormone should really be an advanced clinical topic, because most nursing students really don't know the nuances between the two. I find too that most nurses working forget how they are different. So let's start with this. Both are a problem with the antidiuretic hormone. Both are a problem with ADH. So what does the antidiuretic hormone do? Can you think about it? Let's look at it like this. When you have a diuretic, what is the function of the diuretic? What does diuretics tell the body to do? They tell the body to get rid of water. So if we have something that's antidiuretic, what is it going to tell the body to do? It's going to instruct the brain to tell the rest of the body that we are holding on to water. We are retaining fluid.
So both of these conditions will be a problem with fluid in the body. Now, let's look at diabetes insipidus first, because we can learn a lot from just the name diabetes insipidus. So when we see the word diabetes, what do we think of? Most of you all will say we think of high blood sugar. We think of hyperglycemia. But that is not what diabetes means. The word diabetes means a person who is putting out a lot of urine. That's what it means. It means a person who's putting out a lot of urine. The term after diabetes will describe what that urine looks like. So here we have diabetes, somebody that's putting out a lot of urine, and we have insipidus. The term insipidus means clear, colorless, odorless, tasteless. Because remember, back in the day, doctors used to drink urine to determine what kind of illness a patient has. So diabetes insipidus used to be called water diabetes as well, because the urine looked like water. But it is a problem with too little ADH. So you don't have the antidiuretic hormone in the proper amount, telling the body to keep water, so it just puts it out. It just puts out all the fluid because there's no antidiuretic hormone there. So when you think of diabetes insipidus and the signs are severe dehydration. Yes, because somebody with diabetes insipidus has a very high increased urine output. So the urine output can actually be up to 30 liters a day, which is a lot of urine. Also, because the patient is so dehydrated, they're going to be thirsty. They're going to be complaining of thirst. Now, critically think here. Somebody with diabetes insipidus that's putting out a lot of urine, is their blood pressure going to be high or low? What do you think? Is the blood pressure going to be high or low? The blood pressure is going to be low. So what is the heart rate going to do to compensate? The heart rate is going to increase. So you will have those two vital sign changes. But look at the signs again. Do we see hyperglycemia anywhere in diabetes insipidus? Do we expect the blood sugar to be high? No, not at all. So that's why it's so important for us to study the content, because on the exam, I'm telling you, hyperglycemia will be a choice there to determine if you really know what you're talking about. All right, so diabetes insipidus has nothing to do with blood sugar ranges. So what is the treatment for diabetes insipidus? What is it? Because the client does not have enough of the antidiuretic hormone, we need to supplement what is supposed to be there. So we need to give a medication that's going to act like the antidiuretic hormone. Do you know what that medication is? It is vasopressin. Vasopressin. Yes, vasopressin tells the body to hold on to water. It's really good to also improve low blood pressure. So if you plan to work in the ICU where patients have problems maintaining their blood pressure, vasopressin will be a very popular medication for you. Now that you understand when you have too little ADH, let's look at syndrome of inappropriate antidiuretic hormone, where you have too much of that antidiuretic hormone. You have way too much. So it is telling the body that we're going to save all of the water that we have. We're not going to put out any fluids. So the signs of SIADH are fluid overload. Of course, fluid overload. Also, oliguria. Oliguria is very little urine output. Because the client has an increased fluid intake or fluid overload, talk to me about their sodium level. Will the sodium level be up or down? We would expect that sodium level to go down because of the fluid overload in SIADH. Now with diabetes insipidus, we would expect that sodium level to be way high because the patient is dehydrated. But here, low sodium level. So with the low sodium level, we're also going to see a client that is confused. Yep. So you guys know the condition, SIADH now. Tell me the treatment. What is the treatment for somebody who has too much fluid in their body? What are we going to give them? We're going to give them diuretics. Yes, we're going to give them diuretics. And specifically, the osmotic class of diuretics is going to be best because that's going to help pull water off of the brain too as well. Also, we definitely would want to put these clients on fluid restrictions. So you have this whole page filled out, and now you understand the difference between diabetes insipidus and SIADH. Thank you for studying with ReMar. We're going to keep making it simple for you guys, and we're moving on to the next topic.
Thank you guys for joining me tonight on Winning Wednesday. What you just previewed was one of my lectures from Inside of V2. I hope you learned a lot about diabetes insipidus. Like I said, when I lecture you guys, I try to get to the point quickly because at the end of the day, small steps lead to great distances. And I want you to have your nursing license in 2023. So study with me. I'll see you guys later. Thank you for joining me. Tonight was a pleasure. Question and answer session was amazing. You guys, if you want to start, learning more about the program, please check out ReMarNurse.com. You can also text me directly, the word NCLEX to 855-696-0132. But again, guys, as always, it's been a pleasure. And remember, you can, you will, and you must pass NCLEX. Have a good night, guys. Bye-bye.